Now we move on to second talk, evaluation of the case of pediatric glaucoma by Dr. Neethu Mohan.
I hope the temperature goes down a bit as I go. Yeah, it's better now. Here it's cooler. Okay, so my topic for the day is evaluation of a case of pediatric glaucoma. So how does a case of slides are not moving? Yeah. So pediatric glaucoma differs from adult glaucoma in response to a high intraocular pressure. That is, till 4 years of age, due to the elasticity of the globe, there is an increase in axial length, corneal diameter, myopia, and also reversible cupping in a child. Defining childhood glaucoma, it is in an individual below 18 years of age, the presence of any two or more of the following. That is an IOP of more than 21 millimeters of mercury, optic disc changes suggestive of glaucoma, increase in corneal diameter or abstract, progressive myopia documented by an increase in axial length or retinoscopy changes, or a reproducible visual field defect. The presence of at least one of these would become a diagnosis of a glaucoma suspect. That is an IOP of more than 21 millimeters of mercury on 2 different occasions, a suspicious optic disc or a visual field, increase in corneal diameter or axial length with normal intraocular pressures. The incidence of congenital glaucoma, though it is estimated to be about 1 in 10,000, it is much higher in populations like ours where consanguineous marriages are more common. It's important to rule out conditions that mimic glaucoma, and also most importantly to counsel parents regarding the need for lifelong follow-up, discuss the surgical options, need for multiple surgeries, and to be sensitive to the needs of the parents. The classic triad of congenital glaucoma, as we know, consists of photophobia, blepharospasm, and watering. History would include age of onset of symptoms, gestational history, family history, general pediatric history for anesthetic fitness, as well as considering other associated syndromes, and ocular history. Examination would consist of all these steps. We'll go through them one by one. And it's important to remember that examination under anesthesia is not entirely benign, and multiple exposures can lead to long-term neurocognitive changes. And it is to be considered only when the data acquired will provide a timely diagnosis and also allow surgical intervention, hopefully in the same setting, or it will at least provide follow-up data that will significantly influence the clinical decision making. So as a rule, all inhalational anesthetics lower the intraocular pressure, and the moment the child is intubated, there is an immediate rise in the intraocular pressure. Ketamine causes a transient rise in intraocular pressure. Chloral hydrate and benzodiazepines, there is no change. So be ready to acquire the intraocular pressure as soon as the child stops moving. It is the first test done during an examination under anesthesia. And if the anesthetist allows, it's also a good idea to consider intraocular pressure measurement immediately after pre-medication before the child is induced. So we have this tray ready before an EUA. We insist on this list. We have this list in the OT, and the entire tray is kept ready by the OT sister before the child is induced. And general visual behavior and visual acuity earlier assessed in the clinic should include photophobia, squint, nystagmus, age-appropriate visual acuity. Intraocular pressure can be measured in a bigger child with golden applanation tonometer or Perkins and rebound tonometer during EUA. We do both Perkins and rebound tonometer to have additional values on follow-up. And IOP is the least accurate parameter, and diagnosis is never to be based on an elevated intraocular pressure alone. Anterior segment can be examined with handheld slit lamp or with the operating microscope itself. And this gives a lot of clue regarding the type of glaucoma, primary, secondary, and also has implications on prognosis and genetic implications. Gonioscopy with a direct or indirect lens, and in primary congenital glaucoma, you expect the iris insertion to be high directly into the trabecular meshwork, and a pale amorphous tissue may be seen in the angle as well. Corneal diameter measured by calipers, both horizontal and vertical values, again for more values to have for follow-up. More significant in children less than 3 years of age. And as we know, more than 11 millimeter in a newborn, more than 12 in an infant, and 13 at any age is considered abnormal. Central corneal thickness good to document, though the relevance in children is still uncertain, and CCT corrected IOP is not as reliable an indicator as in adults, but it is to be documented in every child during EUA. Fundus evaluation to be documented by REDCam or by detailed drawing, since this is the most sensitive parameter for diagnosis and progression. It's not influenced by anesthesia or by growth. Axial length preferably by A scan, if not possible at least by B scan. Repeat every 3 to 4 months, and the steepest growth, as we know, is in the first year. And this plotted, the growth of the change in the axial length plotted against the age in months, gives us some indication regarding the growth of the eye, and any variation from normal will be quickly detected if it is plotted on a graph as this. Refraction can be done in the clinic or during EUA, and progressive myopia suggests inadequate IOP control. It is critical to address emmetropia, since amblyopia is the commonest cause of poor vision in spite of good IOP control. Visual fields, around 7 to 10 years, some children may be ready to attempt a visual field. It depends on the developmental milestones, the dexterity of the child, and once the child is able to cooperate, you can try visual fields. Ultrasound B scan may be needed for posterior segment evaluation in some patients, and every unilateral glaucoma should be considered secondary unless proved otherwise, and a thorough evaluation should be done to rule out any possible causes for a secondary glaucoma. UBM may be needed in some eyes before surgery to consider if there are any corneolenticular adhesions and to assess the anterior chamber angle. Disc imaging also may be good to have as data for follow-up. The role of genetic evaluation is still not very clear in congenital glaucoma, and the cost-benefit ratio is not yet well established. To summarize, use every opportunity to examine the child, whether it is in the clinic when the child is sleeping or by feeding, and consider EUA only when the data acquired will facilitate clinical decision making or when you are planning a surgery, and go through the EUA step by step and document all the data for serial follow-up. Thank you.
Thank you, Dr. Neethu, for compilation so fast, and you have finished 1 minute prior.
One thing which I'd like to add is that I always prefer to do a no-touch test prior to doing a touch test. So so that ensures that we and also keep everything ready and maintain a Excel sheet kind of a thing, so that we can properly see as to how the things are proceeding.
Even in the clinic, the technique that you said is better. We finish all the other non-contact procedures and finally we try to force the child for a direct ophthalmoscope. And many times we get away with just when the child is sleeping or feeding or something.
So what is the opinion of the house, the triad, which is actually so often written in the books? How often do you see the triad?
Only see it regularly.
You see the triad. Any other opinions? No. What I'm saying is, they say that every 4 hour photophobia.
Yeah, that's what I'm saying. That before I photophobia, like most of the time they don't have any symptoms, they just come to the eye.
I would agree with Ganesh, because when I was in Bangalore, we used to see it very regularly. But the around 200 population, it's not that bad that they're not born with a white cornea. They usually pick up as a large cornea, at that point it's simply get the patient. So there's a lot of variations. And in Tamil Nadu, we used to have those born with white corneas which are actually sitting outside the eye, literally, and outside the face, literally. Those we're not seeing in Joanna.
And also it's more of the like when I was in Cochin here at Amrita, so there were more of those syndromic children with tetralogy of Fallot or something, which were referred to us as rather than a primary congenital, and they would very often end up having these things. But I did not come across so many people who are complaining of the watering and every 4 hour. So I'll just find it. Jasleen, what is yours? So my question is, you don't see the symptoms, and you were saying
because we see maybe 1 in